Welcome everyone. This is Colleen McCarthy O'Toole from QRSMA's Family Support Department. Thanks so much for joining us for today's presentation on pain management. We would also like to thank our national presenting sponsors, Biogen and Genentech, as well as our platinum sponsor, Accredo, and our supporting sponsor, Scholar Rock, for their generous support of the 2021 Summit of Strength webinar series. We appreciate all the questions that we received today in advance of this webinar, and we're going to try to answer many of these during today's presentation. You are also able to submit questions throughout the webinar using the questions box, which you will find in your GoToWebinar toolbar. Be sure to stay on until the end to participate in the Q&A session as well. Please note that all lines will remain muted during this webinar. If you have any additional questions after today's presentation, please email QRSMA Family Support Department at familysupport@qrsma.org. We'll be starting today's summit off with an opening presentation from Rose Domenico Horn, representing Biogen, who will be sharing their presentation, The Transition from Pediatric to Adult Care in SMA. Rose?
Thank you so much for that introduction. As mentioned, my name is Rose Domingo Horn, and on behalf of Biogen, I will be sharing this educational presentation on the transition from pediatric to adult care in SMA. Next slide, please. Spinal muscular atrophy is a disease which affects individuals across the lifespan. With our advancing knowledge of SMA disease pathophysiology and the underlying genetic basis for disease, we can now think of the range of SMA phenotypes as representing a continuum of a single genetically defined disease, which can affect very weak infants to ambulatory children and adults. With the evolution of the standard of care in SMA and the development of 3 FDA-approved disease-modifying therapies, the trajectories for survival and motor function are changing, and therefore so is the phenotypic spectrum of disease. Next slide, please. In comparison to natural history, patients who receive one of the FDA-approved therapies may experience the achievement of more advanced motor milestones and fewer complications of their disease. For example, an infant with type 1 SMA may respond to treatment, thereby achieving improved survival and better motor function, while still remaining classified under the current paradigm as a patient with type 1. But that child may even improve in terms of their disease progression to the point that they experience a change in what would be the classic phenotypic classification of their SMA type to effectively appear indistinguishable from a patient with type 2. This impact on the evolution of SMA phenotypes with treatment and therapy may occur for any subtype or stage of the disease, including those patients who are identified and treated pre-symptomatically, essentially changing how we think about SMA and how it is classified. As the phenotypes of patients with SMA evolve and patients live longer and healthier lives, it is important to recognize and address the care needs that will emerge as they move beyond childhood into adolescence and adulthood. Next slide, please. The healthcare transition is the process of moving from a child model of healthcare to an adult model of healthcare, with or without a transfer to a new clinician. This represents an evolution from a focus on pediatric care to a shared responsibility for healthcare by both pediatric and adult clinicians. This is especially important as young adults are increasingly being appreciated as a vulnerable population with high rates of behavioral health risks, low rates of healthcare utilization, and susceptibility to emerging or worsening of chronic health conditions. They also traditionally regard healthcare as a relatively low priority when it comes to their transition to adulthood. Traditionally, it has been reported that young adults do not receive adequate preparations when it comes to transitioning to care administration by adult clinicians or within adult healthcare systems. The adverse effects associated with the lack of a structured healthcare transition include medical complications, poor medication adherence, discontinuation of care, higher rates of dissatisfaction, higher rates of emergency department or hospital use, and higher costs of care. Next slide, please. The healthcare transition is part of a larger theoretical framework, which includes but is not limited to these principles: a youth or young adult-centered focus, self-determination and self-management, family and/or caregiver engagement and support, an acknowledgement of individual differences, complexities, and vulnerabilities, the need for early and ongoing preparations and integration into an adult model of care, effective communication, care coordination, and shared accountability, the recognition of cultural and socioeconomic influences on health, and the elimination of healthcare disparities. Next slide, please. While clinicians are becoming increasingly more aware of the importance of supporting a healthy transition of care for their young adult patients, they still report significant barriers, such as a lack of communication and coordination between pediatric and adult care providers, and their often very different practice styles. There may also be a lack of training around childhood onset illnesses among adult clinicians, and therefore a lack of adult specialists available to treat these patients. Parents and caregivers may also not appreciate their role in giving young people ways to increase their independence in seeking and managing their health care. A prominent barrier mentioned by youth with special healthcare needs and their caregivers is a difficulty in leaving the pediatric clinicians with whom they have had long-standing relationships. They may describe this transition as challenging or scary. They may also feel inadequately prepared for or educated about the transition process. Youths with medical complexities and special healthcare needs may have multiple healthcare providers, including nursing and ancillary staff, and may be very accustomed to the routines and services available in their children's hospitals and pediatric clinics. They may require frequent admissions or medical procedures, requiring more in-depth planning discussions with both their children's hospital teams and new adult hospital staff around their transition to adult care. Next slide, please. Documented benefits to a structured transition of care approach exist. Such benefits can be categorized in terms of quality of care outcomes, such as improved adherence to care, improved perceived health status, improved quality of life, and improved self-care skills, and service use outcomes, such as improved adult clinic attendance and a shorter period of time elapsing between a patient's last pediatric appointment and initial adult visit. Decreased hospitalization rates may also result. Due to these benefits and the recognition of the importance of this approach, pediatric and adult practices and systems and public health programs in the United States are increasingly implementing structured processes for a transition to adult care. In pediatric and adult hospitals, complex care centers and transition clinics are being established to coordinate inpatient and outpatient care for youths and young adults, including those with complex medical conditions, recognizing the need for individualized planning and a collaboration between their pediatric and adult clinicians. Next slide, please. One of the ways in which a transition of care is being structured is through the development and utilization of specialized multidisciplinary clinics. Multidisciplinary care is the standard of care for adult and pediatric neuromuscular disorders and has been associated with improved quality of life, resource utilization, and health outcomes. It is delivered by way of the multidisciplinary clinic, in which care can be coordinated across multiple specialties at a single visit. This can help to streamline care and reduce travel burdens for patients, while also facilitating an integrative approach to care, including clinical research and patient advocacy. Multidisciplinary neuromuscular clinics are generally organized around specific neuromuscular patient populations and specialists. They are run by a neuromuscular specialist, generally a neuromuscular trained neurologist or physiatrist, and a team of other clinical specialists, such as pulmonologists, gastroenterologists, orthopedic specialists, social workers, physical, occupational, speech, and respiratory therapists, research and administrative staff, and patient advocacy group representatives. The teams involved in the care delivered at these multidisciplinary outpatient clinics can also help to establish communication and an exchange of clinical information with the clinicians who will care for patients during hospitalizations or inpatient procedures. In the context of a transition of care framework, multidisciplinary care clinics can be useful in establishing a transition of care team for each patient, thereby coordinating cohesive, continuous care across ages as a child approaches adolescence and transitions to adulthood. As mobile health technology advances, it may also be possible to extend multidisciplinary care beyond clinic walls, such as with a combination of telehealth visits, mobile health, and remote monitoring systems, which may improve the timeliness of medical evaluations and interventions, reduce costs, and improve the overall value of care. Next slide, please. Thank you very much for your time today. We hope that this was an educational presentation on the transition from pediatric to adult care in SMA. We at Biogen look forward to speaking with the SMA community again soon. Thank you.
Thank you so much, Rose. Hi, everyone. This is Sarah with SMA's Family Support Department. We would now like to give a warm welcome to today's presenter, Vanessa Batista from the Children's Hospital of Philadelphia. Vanessa shared a wonderful introductory presentation last October on pain management, which you can also find on SMA's YouTube channel. Today, Vanessa will be sharing her presentation, Pain Management, Other Modalities to Manage Pain. Vanessa?
Thank you, Sarah. Is the audio okay?
Sounds great.
Okay, great. Just wanted to be sure. Good afternoon, everyone. Thank you so much to SMA for inviting me back today. It's always exciting to be a part of these excellent summits that are happening, and I'm looking forward to the day when we're delivering them and being together in person. But until then, I think it's awesome that there's such great attendance at these online and that everybody's still able to participate that way. So as Sarah mentioned, we first did a session on pain management in SMA in October and realized from that session that there was quite a few more things that we could have talked about. And so decided to do this as a little bit of a continuum from our last session and to also bring in some other pieces today that we didn't get to talk as much about. So I will give a very brief overview to start of some of the things we did already talk about last time. If you didn't attend the last one, it's totally fine. I'm not going to cover all of the exact same material because that would just be pointless to repeat the same thing. But I will pull out some of the highlights that are as just a way of overview as well. So let's get started. Next slide, please. Okay. So when we think about pain, we may all immediately have a picture in mind, right? What is pain? What does pain look like to us? Or what do we think about when we think pain? What image do we conjure up in our minds? And there are lots of different ways to think about pain. Pain is very individualized, which we're going to talk about. But these are some pictures that just show some of the possible things that may or may not be painful, right? You might think of what's going on inside somebody's brain, and you might not be able to see that pain, right? That's looking at a scan there. And what does that look like if something's happening? There's a picture of a PEG tube there, a G tube, right? Or they have some sort of button on there, an IV, right? This other child here on the end has a nasal interface breathing mask on. And so do we know if anybody's having pain that we see here? We're not sure, right? But we definitely can conjure up a different image of, oh, needle stick, right? How many people think about an IV? I think kids especially think about when you have an IV that you have a needle in your arm. You don't actually have a needle in your arm when the IV is in, right? The needle comes out and it's just a little plastic catheter that stays in your arm, which obviously may feel uncomfortable to still have a little foreign body in your arm, but it's just how we think about things, right? You think you have an IV, it means you have a needle in your arm. So there are lots of different things that we conjure up in our minds about pain. And we're going to talk about some of those things today, and also some of the ways in which we can sort of explore this further. So next slide, please. Okay. Sorry. So pain, by definition, is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So if you notice, by definition, pain can be a sensory experience, meaning that you're actually having a sensation of pain, or an emotional experience. So there may not always be something physical going on with pain, right? There are lots of different kinds of pain. There's emotional pain, there is psychological pain, there's suffering on many different levels at times, but it's actual or potential tissue damage, and what sensation is that damage causing, right? And what's the experience associated with that? So for a lot of these things, pain, anxiety may come along with it. A lot of this is just the perception of what's going on for the person who's experiencing it. Next slide, please. So pain is subjective. I think I mentioned that already, but pain is whatever the person who is experiencing it says it is. It is, if I say something's really painful and someone says, oh, that didn't hurt at all, you have to listen to the person who's experiencing it. And I think this is something that's especially important in pediatrics, because we are sometimes quick to say to children, oh, it won't hurt at all, or it doesn't hurt. And although you want to always reassure a child or an adolescent or even another adult, whoever it may be, that something's not painful, if they experience it as painful, then that means it's painful for them. So obviously we don't want to go to the other end of the spectrum where we have people afraid of things all the time and always worried about pain. But it's not helpful to often say, or it's often not helpful to say, oh, that doesn't hurt, don't worry. What we try to reframe it is to say, it may hurt a little bit, but it's only going to hurt for a second. And that can sometimes also bring about anxiety, but you want to be honest about, no, it may actually hurt to get a needle stuck into your arm, but it's not going to last, right? The pain's going to be quick. And I can tell you, we were laughing about this recently because I've been, volunteering in the clinics here giving vaccines. We're vaccinating school teachers in Philadelphia, and we've been joking that sometimes the teachers are more nervous about getting a needle than probably some of the kids that we're used to seeing in clinic would be, right? It's like people automatically, you say needle and there's that association with of that fear of pain. And it's such a small needle we're using that, just like I would do with children, if I distract them enough, they didn't even notice that I gave the needle already, right? Someone said, that's it, I said, you're done, you're vaccinated, and they were like, you gave it already? And so I just talked them through it, right? So, but it's whatever that, it's right away you can see people tense up, whether you're an adult, a child, whatever it may be, of just that notion of something painful is coming. So it is very much an emotional and a physical experience, especially if you've experienced something before. We see this in kids, right? Or again, kids, adolescents, as people get older, what's your memory of pain? Did you already experience something that was painful at some point? And sometimes it means you habituate to it and it doesn't bother you as much. And we see this a lot in people that we care for, right? That they have been to the hospital a whole lot of times and experienced the same thing over and over and it doesn't faze them. Or we see the opposite end of that spectrum where there's that fear. I recently saw a child in the Neuromuscular clinic here who was not very fearful of me at the last visit, and some of it may have been age, but was quite clingy to his parents when I saw him again last week. And I said, oh, things are changing. And there was like, well, there had been a trip to the emergency department somewhere in between those two visits. And so the parents said, oh yeah, he's been a lot more fearful since that visit. So it makes sense, right? Children have memories of things. And again, when I say children, I mean to include adolescents as well, but the whole spectrum, and anybody can have that memory, right? Even if you're an adult. So it is modulated by developmental, behavioral, psychological, familial, and cultural factors. Certainly, what's the perception of pain for that person from their previous experiences, from their family, right? Some families have a pick yourself up by your bootstraps, be tough kind of mentality of this is no big deal, you've got to be tough, you've got to take it. Other families may not have that same viewpoint and have another viewpoint. A lot of this is also influenced by culture. And so for whatever the person is experiencing, you want to take all of these things into account and really think about how they factor in. And the best example I can give you is a personal one coming from my own family. So I'm first generation Italian. My parents are both from Italy, and there is sort of a mentality of you have to suffer. So I joke around if I go to my parents for a visit that I bring my own Advil with me, because if I happen to get a headache while I'm there, there will not be any Advil in the house, right? It's part of their sort of cultural of, why would you take a pill for something? Because you just have to kind of suffer through it. And so, I have perhaps a different philosophy for the way I grew up here, but it's part of their cultural beliefs and probably part of their personal beliefs, but everybody is going to have those, right? And so you have to really take that into account. Some people have a notion of, giving medicine for pain is bad, or it makes you weak, or I'm not saying any of those things are true, but it's just people's different perceptions. Sometimes people will tell their family member that's experiencing, you got to be tough, you got to stick it out. And so you want to be really mindful of what is the experience of pain. Is it something that they've gone through before, and what are all of the factors going on there? Because once you start to understand some of these things, then you can begin to approach pain in a way that's going to help you come up with a plan to help make that person more comfortable and hopefully suffering less. Next slide, please. So let's talk about some of the different types of pain. And I did review this a little bit in the last presentation a few months back, so I won't belabor this. But I think it's helpful to just think about this context in mind when approaching this. So acute pain is something that usually begins pretty suddenly with, there may be a warning of a threat and lasts less than 3 months. So I'm sure if we were live, I'd ask somebody to raise their hand. We can't do that right in this moment, but I'll ask you to just think for a moment in your head about what that might be. What's acute pain, right? There might be a warning of that threat. And so I think of something like burning your hand on a hot stove, right? It's that acute, there may be a warning if you saw a flame or saw that it was, red or hot. And we see this a lot in kids who put their hand on something hot, right? It begins suddenly. As soon as you touch something that's hot, the pain doesn't last a long time, but it's more acute pain. And then chronic pain is something that lasts beyond the time of that stimulus. There's no necessarily protection for it, protective mechanism in the sense that makes it go away immediately. And by definition, chronic pain is usually pain that lasts for 3 months or longer, so longer than 3 months at a stretch of time. So that would be chronic pain. And an example there would be something like chronic headaches or chronic back pain, or could be muscle pain, or something that someone's living with for an extended period of time. It doesn't mean that it never goes away. It doesn't mean if you have chronic pain that you have it for life. It just means that it's pain that's been around for a while. It's been ongoing. Recurrent pain would be pain that alternates with pain-free periods, and an example of that would be a headache, right? You might not have a headache all day, every day for your entire lifetime, but it would just be periods of on and off of having headache pain and not having headache pain. And total pain is something to really pay particular attention to. Hopefully you won't know many people who experience this. It's very difficult. It's difficult to treat. It's certainly difficult to live with, but total pain is when there's pain across more than one domain. So physical, emotional, social, and spiritual aspects of someone's life. And the pain may alternate between different areas, but we see this a lot as people progress in their disease, and sometimes if they may be getting sicker, they may, for example, make it the physical pain pretty well controlled, but are they suffering on some other level, like struggling with their spiritual beliefs, thinking about, how could God let this happen to me, or why is God letting my child be sick in this way, or some other emotional, relationship issues that things are being brought up. So it's pain that crosses more than one domain and really overtakes somebody's life. And it's very difficult to treat just because it's hard to resolve all those things, right? The physical part, we can't always get to 100% pain-free, but we can do a lot to try and get that under control. Some of the other pieces just take time to work through, and sometimes people don't get all the way there in the end. And so you want to just think about what are some of the different kinds of pain as you make your approach to how you're going to best manage it. Next slide, please. So a few caveats on pain here. It does affect all areas of life, which I've talked a little bit about. It's multifactorial, meaning physical, psychological, and emotional. Finding the source can be difficult and complicated. We don't always know. It's not always so clear. For example, the example I gave before about burning your hand on something hot. It's not always so clear that, oh, look, you touched the hot stove and now you're having pain. Sometimes you may not know the cause of pain if there wasn't a direct injury, or something we see in SMA, right? There may be a fracture and you had no idea when or how that occurred. I'm sure some of you that are listening right now have maybe experienced this, where you yourself or your child had a fracture and you weren't even aware that it was there, and there was a lot of crying and a lot of pain, and you weren't sure, and it took some time to figure out that, oh, there had actually been something going on there. And so finding the source can be a challenge, especially when it's psychological or emotional or has other aspects involved. You have to figure out where the pain is coming from. But untreated pain can cause damage and affect function and quality of life, certainly overall. And learning skills to cope with chronic pain is essential. We certainly would not advocate for just somebody living in pain all the time, but if there is pain that's ongoing, you want a plan in place to manage that. And it doesn't mean you can always make it go away entirely as much as you always would like to and want to keep that as the goal. There are times when you can't promise pain will get to zero, but it's more of how can we optimize your functioning or optimize your quality of life as much as possible so that we can have you live with this pain in a way that feels manageable to you. So what are those skills, right? Are there pharmacologic things that we can do, and also non-pharmacologic things we can do, which we're going to talk a little bit about as well. And you want to always be mindful of the developmental level, whether you're thinking about children or adults experiencing pain, that there may not be the right words or language or ability to really adequately describe pain, and so pain may be undertreated for that reason, because especially before children are verbal, they might not be able to tell you something hurts and you're not sure exactly what's going on, or they can't describe it. I asked a little girl a couple of, I don't know, maybe weeks ago, maybe a month ago, during an exam I was doing in clinic, and said they were saying that ouch when I would near them. And so I said, well, does it hurt here? And the response I got from her was, it doesn't hurt everywhere. So kids are often really adorable in how they describe things to you, but it may not be all that helpful, right? So it was a great response, but it didn't really help me figure out where the pain was coming from or what was going on. So you want to just be mindful of that, given the developmental level and also the chronologic age of how somebody can describe their pain to you and help you understand it better. Next slide, please. So untreated pain directly affects quality of life. It can put a stress on relationships. It can cause moodiness. I know I can tell you on instances when I've been not feeling well for whatever reason, or having pain from something, I don't know, broken bone, whatever it may have been, like I'm not usually in a good mood when I'm having a lot of pain, right? And so you can imagine, especially if you're living with chronic pain, how does that affect your quality of life over time? Do you sleep less because the sleep is interrupted by pain? Is there a loss of independence associated with that pain? Is there decreased appetite, just stress all around, right? So certainly can impact different areas of life and different domains of quality of life for sure. Next slide, please. So what are some concerns? And I say parental concerns here, thinking about caring for someone who might be living with SMA. If you're a parent who's the one that is the caregiver, it may be some things for yourself, but thinking more about the child and the adolescent here, we could take out the word parental and just say, what are some concerns, right? But that treating pain means giving up. And these are concerns, but not necessarily truth. So sometimes there is that notion, or some people may think that treating pain means you're sort of giving in. Again, that idea of I have to be tough and just get myself through this. There's also the misconception that opioids may be too strong for younger children or even adolescents, that there's this fear of addiction, and what we know is that if pain medications are used appropriately, then you will not be causing addiction. Someone may become tolerant, meaning that they need more of that medication over time to have the same effect, but when used appropriately as prescribed, you should not be creating addiction to some of these pain medications. There's also the fear of side effects, right? And unfortunately, most medications used to treat pain do have some side effects. So it's often impossible to avoid those, but those can certainly be very valid concerns. Again, cultural religious beliefs surrounding the meaning of pain, which I mentioned earlier, that idea that you're supposed to be brave, not knowing how pain can be treated, so not really knowing what to do about it. And again, first figuring out the source and knowing, we'll talk a little bit about this as we get further here, but in SMA, right, it might not be pain medication. It might just be other things that you need to do to try and get that pain under control. Not having a language to report pain, worry about medications, and that might be from past experiences, and worried that they will not be able to do something they want to do if they report having pain. And so we will see this a lot of times if somebody's looking forward to doing something, they might not want to tell you that they're having pain because there's that fear of, well, if I say that I'm having pain, then I'm not going to get to have my, play date with my friend, or I'm not going to get to go out with my friends on Friday night when we were allowed to go out with our friends on Friday night prior to the pandemic, or, I'm not going to be able to attend something I wanted to attend or do something I wanted to do. And so sometimes there may be this trying to cover up pain for those reasons. Next slide, please. So what are some tips to go along with those concerns? Keeping a pain history certainly helps, and this helps us try and understand what the pain is caused by, perhaps, or where it's coming from, when is it occurring, trying to put the pieces of the puzzle together, so to speak. So what's the quality or the nature of the pain? What was happening when it started? And that can be, you may think, well, why would a diary help tell us where the pain is from? But if you look back through a couple of weeks and you notice a pattern of, seems like the pain is always after lunchtime, or seems like the pain is always when someone wakes up in the morning, or looks like the pain is, always waking up in the middle of the night, maybe you can start to figure out what's happening around that time, right? If it's always after lunchtime, is it something having to do with what they're eating, or the way they're eating, or the pace they're eating at, or whatever it may be? If someone is receiving feeds through a feeding tube, is it something going on with that? It's just different things that you want to think about that we always think we're going to remember at the time, but keeping a diary, just jotting it down, doesn't have to be fancy. It can just be, a lot of people just do them in their phone right now because it's the easiest way, right, electronically somewhere, to just be able to look back at patterns over time. And you can't blame people when they're poor historians and they come in for a visit, but you ask them, well, what time did the pain occur 2 weeks ago? They're not going to remember what went on that day, right? I know people are busy and have a lot going on, but just even jotting something down quickly can be very helpful. You want to also include the onset and the location. Was it sudden? Has it been ongoing? How long does it last? And how often does it occur? Is it quickly? Is it frequently? What makes it better or worse? That's always an important question to ask. If someone tells you, ice always helps it feel better, or warmth or putting heat on it makes it feel better, or, taking some acetaminophen or ibuprofen makes it feel better. You want to know, massage, whatever it is. What makes it worse, right? Or it feels a lot worse when we put ice on it. We tried that and it really didn't feel better. Or it feels a lot worse when somebody touches it or tries to massage it if it's, a limb or something that's hurting. So you want to always be taking note of all of these different factors. Describe the pain. Is it throbbing? Is it sharp? Does it radiate to anywhere else? Is it, if you can, point to it with one finger. Where does that pain occur? Is it pinpoint pain that's in one spot, or is it more, visceral pain that may be spread over a certain area? And what's the timing of the pain? Does it happen at set times, as I mentioned already? So keeping a pain history can be very helpful in trying to look at the whole picture of pain. Next slide, please. So some more tips specifically about pain medication. You want to, if you are using medication to treat pain, which you might not always be doing, but again, I'm not going to go over all the opioids today because I did that last time, but if you are in fact using medication, whatever it may be, to treat pain, you want to not wait for the pain to be so severe before treating it. Give it at regular intervals to stay ahead of the pain before the next dose is needed. So if something's every 4 hours, you don't want to wait until 3.5 hours and someone's in excruciating pain to really see if they're going to need pain medication. Again, you want to just plan that okay, the next dose is coming and you'll be getting pain medication again. You want to try and do that to stay ahead of it so that you never get to that 3.5-hour mark of being in excruciating pain. And if that's happening, then you need to make some change, right? Either give more medicine or give it more frequently or whatever. Obviously, something that's safe to do. You want to be talking with a clinician about that, but you want to think about, what adjustments may need to be made if someone's constantly having pain in between being on doses of pain medication. There's no single medication or dose that will work for everyone. And you also, especially in children, want to think about the risks of treatment and potential side effects for anybody really, but really being careful of what are the trade-offs there, and things like, children's body systems aren't as mature. Body systems are not as mature, and so you want to be careful sometimes about giving some of these pain medications. Are we putting too much stress on the liver or the kidneys or wherever that medication is cleared? So you always want to think about what you're doing when you're prescribing pain medications. Next slide, please. So let's talk a little bit now about SMA, the reason why we're all here, and what are some of the possible causes of pain in SMA. And we all know that pain is not an inherent part of SMA. It is not a disease where we say, okay, these are the symptoms you may experience, and usually list pain as one of them. Pain is usually secondary to something else that's going on. And the biggest thing in SMA is usually something musculoskeletal that might be causing pain. Is there joint pain from contractures somewhere? Is there scoliosis that's causing pain? Hip subluxation, which may cause pain. Contractures, which I mentioned, at any joint that can be very extremely painful if somebody stays in that position for a long time. Sometimes I have people just hold, I can't see if you're doing it, so you'd all be cheating, but just hold their arms up when I'm talking about pain and say, oh, there's no such thing as pain in that disease. Well, hold your arms up and squeeze them the entire time I'm talking, or just a few minutes of me talking. And if your muscles are contracted for long enough, you're eventually going to have some pain, right? And so, you may not think about pain inherently, but what else might be going on? Certainly, if somebody's having muscle spasms or cramping or just contractures or tightness from not stretching, there's going to be some pain there secondary to that. Is there a fracture? Is it positional? Is it equipment that's causing pain, right? How frequently do we hear that night braces are causing pain? Or how frequently do you, as a person experiencing this yourself, have pain from your night braces? Hopefully it's not every night. If it is, there needs to be some adjustments made. But I saw somebody today who said, I don't wear the night braces anymore because they hurt. Right? Immobility can cause pain, just pain in your hips from not walking on different body parts. Are there pressure sores or pain after procedures, like a scoliosis surgery or having some other procedure done? Next slide, please. So this is just a little table to categorize some of the things I already mentioned, what might be some of the considerations. So for example, scoliosis, the curvature can be causing irritation of nerves, but it can lead to leg pain or affect breathing, depending on how the curve is positioned and what the effect is in an individual, and what's treatment for that, right? So it may or may not be pain medication. It may be something more like physical therapy or occupational therapy, right? Often the most important piece in SMA. The therapists that are working with someone to try and get them comfortable and to live most comfortably and have the maximal quality of life, right? Is there bracing that's needed? Is there surgery that may be recommended? And there may be medications as well, and sometimes a combination of both. Contractures, again, are a lot of those same things. Repositioning, maybe heat sometimes, perhaps medication. Gabapentin can help if somebody's having more nerve-type pain, sharp shooting pain. Hip dislocation, usually observation by the surgical team or an examination to really figure out what's going on. Usually surgery is not needed, but really just observing that over time. But you want to get that thoroughly assessed as well. Next slide, please. So what are some of the pharmacologic adjuvants? And I'm going to just cover these a little bit here briefly because this is really not all about medications, but I know last time we talked a lot about opioids, but did not talk about some of the other medications that may be useful in treating pain. And so you'll see here just a list of medications that may be useful in managing pain that are not necessarily intended just for treating pain, but may be useful in that way. So sometimes we use anticonvulsants. So that's the class of medication. For example, gabapentin would be something. It's actually an anticonvulsant is the class of drugs that it's in, but we would use it as for nerve pain. So you want to think about some of these other uses for things. Antidepressants may also be helpful with pain. Sometimes you get double benefit from that if somebody's having some depression along with their pain, which can certainly have some depression if you're living with chronic pain. So sometimes some of these things manage more than one thing. Cannabinoids are being used more and more now. Muscle relaxants, I'm sure a lot of you are familiar with things like baclofen. Clonazepam may be used, but what are the things that help, especially if someone's having contractures? These things may be useful. Not always. Again, it's not one size fits all. You wouldn't always prescribe medications or the same ones, but you want to think about that. Steroids can sometimes be helpful in treating pain. Topical anesthetics if it's something in one spot, and ketamine is also used to manage pain as well in some extreme instances. Next slide, please. So I'll take you quickly through these. Gabapentin, some of you are probably very familiar with. It's used very often in the world of neurology, certainly for this type of pain, this sort of nerve pain, so to speak, but it's an anticonvulsant mechanism. We're not sure exactly how it works in managing pain, but it is commonly used in pediatrics. It has similar efficacy as something like amitriptyline. It's not usually very sedating, although when you're starting, you always want to titrate up to make sure somebody doesn't become too sleepy right away. And then it needs to usually be weaned off, or always be weaned off, to decrease the risk of surgery. Of a seizure. Something flashed up on my screen, I think from the computer here, and covered my screen for a second. So hopefully not having a seizure, but it was a weird thing that flashed up. So, but anyway, so you want to think about always titrating up gabapentin and always weaning it down when you're stopping somebody on gabapentin. And there's no IV formulation, so it's not something that you give for immediate relief, although it's pretty quick acting, but it's something that you have to give in a pill form. Next slide, please. The one thing I will, go ahead if you can move to the next slide, please, but I will just say about gabapentin that you want to make sure you're giving the right dose, because sometimes we undertreat and don't give enough of it. So it can be very effective if we give the adequate dose. Tricyclic antidepressants can be very useful for pain management. Again, for neuropathic pain, it can be helpful. These are sort of maybe off-label uses in some instances, although now we know pretty well that they're helpful in pain. They can be very sedating and have some side effects, and there's a fun little picture there for you that we use when we think about how to summarize the side effects of antidepressants. Like, what are the anticholinergic side effects? Or hot as a hair, dry as a bone, blind as a bat, red as a beet, and mad as a hatter. So, those are the side effects and things that can occur. So you want to be careful with using these, but if they are really intolerable side effects, you can reduce the dose and then slowly increase back up. And you always want to get an EKG when starting the use of these as well. Next slide, please. So let's think about disease-specific treatment for a minute, and I'm going to sort of move through this here, but depending on the type of pain, you want to manage make your pain management plan to focus on what type of pain. So we know certain things may be useful for bone pain or bowel spasms or muscle pain or neuropathic pain. So we always want to think about, it's always not a one-size-fits-all fit for these kind of things. Next slide, please. Ketamine, I'm just going to talk about briefly because somebody had asked last time about this, but it is often used to treat pain. It is not something that's very frequently used at home unless you're like talking about somebody at their end of life. We might sometimes use it at home, but certainly not for somebody who's living chronically with the disease. We don't prescribe ketamine for use at home. It can be used in the hospital in extreme instances. It is an NMDA receptor antagonist and can be used sometimes to reset sort of the pain receptors when there's been an increased reaction to pain. It can be used sometimes for neuropathic pain in low doses or sub-anesthetic doses. You don't want to entirely put somebody to sleep, so to speak, but it does not depress cardiac and respiratory symptoms, but it can have some side effects. Like you hear people talk about really wild dreams when they're on ketamine. And again, this is something for often used when nothing else is working, but I just wanted to bring it up because someone did ask about it last time and we didn't get to it. So next slide, please. So we're going to move now into thinking about some of the other things that go along with pain and how we manage them. So I included anxiety here because I think it's very common for someone to experience some level of anxiety when they're having pain. And you want to think about approaches to anxiety. Certainly there are medications that may be used. Benzodiazepines are often the ones that are used. But you want to think also about non-pharmacologic management. So what are some of the things you can do to decrease somebody's anxiety when they are experiencing pain? You also want to think about delirium if someone's, especially if they're in the hospital or having pain that seems to be going on and on, you can't get under control, what else might be going on there? And this is not something that's very common, especially in SMA, but if someone's really having a lot of pain, maybe an acute instance of pain where they're in the hospital for something, you want to think about all the things that go along with it and just be mindful of the fact that any pain can cause somebody to have some anxiety. Next slide, please. So we're going to talk about medication or non-pharmacologic pain treatments now. This is just a chart that shows you by age some of the things you may think about. So for infants and toddlers, it may just be the things that make them feel better, right? Swaddling or wrapping them, position changes, gently massaging. And then as children get older, school age, adolescents, and adults, things that you can do that may be more age appropriate. We're going to go through some of these. Next slide, please. So hot and cold therapy is one. You want to know what works. If hot makes it feel better, then great. If cold makes it feel better, then great. But usually when we think about cold, it's decreasing inflammation, and warm is increasing blood flow. So if somebody has, a fracture, we usually would go with cold and not heat because we want to decrease inflammation. So you want to just think about whether hot or cold compresses or a heating pad or something like that that's obviously being used safely, would that help at all? Just things to think about. It can be very helpful if somebody's having pain in one area. Again, not going to get rid of it entirely, but maybe helpful. Next slide, please. TENS units can be helpful for pain in certain areas as well, something to consider. Not always used, often used in physical therapy though for musculoskeletal pain. Next slide, please. So let's talk a little bit about integrative therapies. I know there's been a lot of wellness sessions going on here from Cure SMA, so I won't go into these in great depth, but we'll spend our last few minutes talking about some of these integrative therapies by way of overview, and then I'd be happy to discuss some of them more if people have questions about them. But we say integrative therapies because we should never be using these instead of other treatments. They're often used along with other treatments for pain. Sometimes they may be used instead if they're the thing that works, but you don't want to think about starting some of these alternative or integrative therapies and stopping pain management plan that you have from a physician or your provider, nurse practitioner, whoever it may be. You want to really think about having a plan that puts all the pieces together. So the use of conventional therapy as well as complementary therapies together in an individualized plan of care. So what works for that individual person who is experiencing pain. Next slide, please. So therapeutic touch and massage, two separate things, but often used together and very similar to each other. But therapeutic touch, by definition, is an intentionally directed process of energy exchange during which the practitioner uses the hands as a focus to facilitate the healing process. That's just the definition there. And the massage is the systematic and scientific manipulation of soft tissues of the body. So massage may sometimes be targeted more in one area or be more intense, whereas therapeutic touch may be really just laying hands on someone to help move energy around. And there are people who are trained in these modalities. So if someone's trained in therapeutic touch, then they would know exactly how to use it to help somebody feel more comfortable. But kids often, the younger kids in the hospital, really enjoy this sometimes when it's done properly. So next slide, please. Guided imagery, very useful technique for many ages, a little bit hard to do in younger children, but very helpful. And that's the deliberate use of imagination to help the mind and body heal, stay well, or perform well. So can you think about bring your mind to being in another place and focus on that instead of where you are, where there is that acute pain. So almost mentally taking yourself someplace else. And this has been very effective for people of many ages and many different circumstances. So certainly a great tool to have in your toolbox. Next slide, please. Reiki is an ancient healing art which involves gentle laying of the hand. Again, energy throughout the body, and it's described as being different chakras that energy is moved through. And again, you want to go to somebody who knows how to do this, so a Reiki practitioner or a Reiki master, but we have this available in our hospital. Not every place has it, but for inpatient use, at least here, and you can get this outpatient as well, but can be very helpful in the management of pain. Again, you want to make sure that it works for the person and that you have to go to somebody who knows how to do this properly. Next slide, please. Acupuncture is the stimulation or penetration of anatomic points on the body with thin, solid metallic needles that are manipulated by hand or by an electrical stimulation. So not painful. It shouldn't be deep enough where you're really feeling pain, but just very lightly placed needles throughout the body that helps to move the energy again, and can be very, very, very effective for the management of pain, especially chronic pain. And there's different forms of this as well, like different kinds of things that are done with needle therapy, and they're listed for you there that can often be used in combination. Next slide, please. So this is just a joke about acupuncture, right? That's odd. Suddenly my neck feels better. Getting lots of needles, so to speak, there. Next slide, please. Mindfulness meditation is the mindfulness meditation or mindfulness-based stress reduction form of meditation, MSBR, or it should be MBSR. That's flipped there. It was like I went to say MBSR and realized it's wrong on that slide, so I apologize for that. But this was started by Dr. Jon Kabat-Zinn in 1979. He's written several books about this, and it's a practice that's very widely used today in many different circumstances, but can be very useful, again, in just meditation to guide somebody through coping with their pain. Next slide, please. And here is just a quote about that. Life can be found only in the present moment. The past is gone, the future is not here yet. And if we do not go back to ourselves in the present moment, we cannot be in touch with life. So mindfulness is about being in that moment where you are. Next slide, please. Aromatherapy is the controlled and skilled use of essential oils to maintain health and well-being. And this is really works with somebody's perception of pain. So you're not necessarily going to claim to take away the pain, but again, what is the sensation of feeling anxious or depressed or whatever it may be? If someone's having that feeling of being out of control when they're in pain, aromatherapy can be very helpful for that as well. Next slide, please. Music therapy, again, great thing, often available inpatient. If you can find it outpatient, that's great, but maybe music classes or things like that. Again, some of these things aren't going to take away the cause of the pain, but can just really help people cope with pain. And a lot of it's just about distraction, right? Not thinking about the pain all the time, but this is something that can be very helpful. Next slide, please. Coming to the end here. Pet therapy can also be great. Those of you who have pets at home probably know how they always make you feel better and sometimes maybe drive you crazy, but for the most part, hopefully make you feel better overall and can be very effective in keeping somebody calm or not having as much pain. So there's a picture of our little friend there. Next slide, please. And therapeutic yoga, again, if somebody is able to participate in yoga, can be very effective for pain. And we offer groups here a lot for younger patients as well, or younger people, but also for adolescents. They find this really great. We offer several different groups here at our hospital, but this can be done locally as well. And again, it may need to be modified for someone's physical status, but can be very helpful in managing pain as well. And I think that's our last slide. Is there another slide? There you go. So I think we've come to the end. Please submit any questions or comments you have in the Q&A box. And now there will be another presentation. So thank you so much. I'll be back for questions in a few minutes.
Thank you, Vanessa. And like she said, we'll be coming back to her shortly to answer any questions that have come in. So viewers, you do still have time to submit questions, no worries. But first, we'd like to introduce Jennifer Fuller. She is representing Genentech and will be presenting a brief introduction to Evrysdi. Jennifer?
Thank you, Sarah, and thank you, QRSMA, for the opportunity to be here. Today, I'm going to provide a presentation on Evrysdi, which is proven to make a difference in infants, children, and adults with SMA. Next slide, please. Thank you all for joining me and sticking through the very end. As Sarah mentioned, my name is Jennifer Fuller. I'm a Partnership and Access Liaison, or PAL for short. I have the privilege of serving the SMA community in the San Antonio and Austin, Texas areas. This photo here is a group of all my fellow PALs across the country. Most of us have healthcare backgrounds, but it's important to note that in this role, we aren't able to provide any medical advice, as those are conversations you should always have with your doctor. But what we are here to do is answer your question and connect you to resources. Next slide, please. So today's discussion, it'll be a brief 10 minutes, and I'm going to cover 4 key topics. First, what Evrysdi is and how it works. I'll talk about how it's being studied, and I'll share some of those clinical results with you. I'll talk about how to take Evrysdi, and last but not least, I'll share some of the support services that we offer here at Genentech. Now here at Genentech, we take safety very seriously, so I'd like to go ahead and start there. Next slide, please. There's some important safety information to share with you. Before taking Evrysdi, tell your doctor if you have liver problems, are pregnant, or plan to become pregnant, or are breastfeeding or plan to breastfeed. Evrysdi may harm an unborn or breastfed baby. Evrysdi may affect a man's ability to have children or his fertility. Tell your doctor about all the medications you take. Now, these are not all the possible side effects of Evrysdi. It's important to view our full prescribing information, which you can find at evrysdi.com. So what is Evrysdi? It's a prescription medication used to treat spinal muscular atrophy in adults and children 2 months of age and older. It is not known if Evrysdi is safe and effective in children under 2 months of age. So now let's talk about how it works. Next slide, please. And continue. So as most of you know, in SMA, it's a genetic condition caused by the shortage of a key protein called survival motor neuron, or SMN. Now, Evrysdi targets our backup gene to help make and maintain more SMN protein. Evrysdi increased and maintained levels of SMN protein. In clinical studies, within 4 weeks of starting Evrysdi, median SMN protein levels more than doubled and were maintained throughout 12 months across all SMA types. So now that we know how it works, I want to share some of the clinical trial information with you. And I'm going to start by sharing a little bit of information about the participants. Next slide, please. Evrysdi continues to be studied in a broad range of people. As you can see here, that includes more than 450 people across all 3 types of SMA. And they range in age from 2 months all the way up to 60 years of age. Now I'd like to share a little bit of information about the design of our clinical trials. Next slide, please. As you can see here, there are 3 different clinical trials referenced. I'd like to call your attention to the one on the left in hot pink, Firefish. Firefish included infants with type 1 SMA. And to your right in yellow, Sunfish, this one included children and adults with type 2 or 3 SMA. Now, both of these clinical trials had 2 parts. The first part was exploring a recommended dose of Evrysdi, and the second part was looking at the safety and effectiveness of Evrysdi. Now, they were designed a little bit different in that Firefish was open label, meaning all infants received Evrysdi. Now, in Sunfish, it was a randomized placebo-controlled study, which means there were 2 different groups, and participants were randomly assigned to each. One group is those who received Evrysdi, and the second group did not receive Evrysdi. They got a placebo, or an inactive ingredient. And those two groups were compared. Now, the results of these two studies are what granted FDA approval of Evrysdi. The third trial you see there in the bottom in blue is called Jewelfish. This is an ongoing supportive study that is specifically looking at the safety of Evrysdi in all three types of SMA in people who were previously treated with other SMA medications. So now that we know the design of the trials, let's go ahead and take a look at the results. Next slide, please. So I'd like to start off with sharing the results of Firefish. Now in Firefish, we looked at a specific measurement, and that was the ability of infants to sit for at least 5 seconds without support. The results revealed 41% of infants were able to achieve this. Now, as you all know, in an infant with type 1 SMA who remains untreated, they're not expected to be able to achieve this milestone. There's another key observation with Firefish I'd like to share with you. Next slide, please. Evrysdi also helped infants survive without permanent breathing support. This was assessed at 2 different time periods. At 12 months, 90% of infants were alive and could breathe without permanent support. At 23 months, 81% were able to achieve this. So now that we have some results from Firefish, let's go ahead and look at the results from Sunfish. Next slide, please. So children and adults treated with Evrysdi and Sunfish showed improved motor function versus those not taking Evrysdi. A change in motor function was measured over 20 months, and this was measured using a specific scale, MFM32, or Motor Function Measure 32. Now, this is a scale that has 32 elements assessing head, trunk, and upper limb motor function. What that measurement revealed is illustrated in the graph here. The top blue line with dots indicates those who received Evrysdi, and the gray line below that with dots is those who did not get Evrysdi. As you can see here, those taking Evrysdi showed an improvement as their average score increased, and those not receiving Evrysdi had a decrease in their score. So now that we know a little bit about the results, I'd also like to share some results as it pertains to safety in these two studies. Next slide, please. As I mentioned earlier, safety is so important here at Genentech, and it continues to be studied. Now, there were some common side effects reported, and this is broken down into 2 different trials. On the top, you can see there in Firefish, the most common side effects reported were fever, diarrhea, rash, symptoms of upper respiratory infection, such as runny nose, sneezing, sore throat, and cough, also lung infection, constipation, and vomiting. Now in Sunfish, the most common side effects reported were fever, diarrhea, and rash. Now these are not all the possible side effects of Evrysdi, so it's important if you're considering it to make sure and have a conversation with your doctor and discuss the risks and benefits. Now one other point I'd like to mention here is after taking 12 months of Evrysdi, no one had to stop taking it due to side effects. So now that we talked a little bit more about safety, I'd now like to go ahead and talk about how to take Evrysdi. Next slide, please. Evrysdi is the first and only medication to treat SMA with at-home dosing. And that's because it's a liquid treatment taken by mouth or feeding tube that's taken once a day, every day. It's delivered directly to your door, it's stored in the refrigerator, and you are provided with the appropriate syringes to measure your dose properly. Now, your dose will be determined by your doctor, and this will be based on your age and weight. So now I'd like to go ahead and go to our 4th topic, which is some of the support resources offered here at Genentech. Next slide, please. Here at Genentech, we have an entire support program dedicated to the SMA community, and it is called My SMA Support. As PALs, we are an important part of the support program, and we are here to support you in several ways, some of which are listed here. We can provide education on Evrysdi, similar to what you're seeing today. We can help you understand your insurance coverage, as well as discuss potential financial options if needed. We'll connect you to resources, and we'll coordinate with your specialty pharmacy, Accredo, each and every month to ensure your deliveries. As a reminder, as pals, we're not able to provide any medical advice and would definitely encourage those conversations to be had with your doctor. So now I'd like to go ahead and summarize some of the 4 key areas we covered today. Next slide, please. So 4 key areas we talked about. Let's check the boxes and make sure we covered them all. I started with sharing some important safety information with you. Just as a reminder, safety continues to be studied, and it's studied in people 2 months to 60 years of age in all 3 types of SMA. I then shared with you how Evrysdi works and how in the clinical studies, Evrysdi increased and maintained SMN protein levels. I then shared with you some of the trial results and how Evrysdi improved motor function scores in our 2 main studies, Firefish and Sunfish, which was inclusive of infants, children, and adults. I then talked about how to take Evrysdi. Remember, it's the first and only oral treatment for SMA that is delivered to your door each and every month. Now, I realize we covered a lot of information today in a short period of time, and you may have additional questions. So here's what you can do. Next slide, please. First and foremost, if you have questions, always contact your healthcare provider first, as they are your primary resource of information. You can also connect with a PAL, and you can do that by going to smasignup.com. There you can enter your zip code, and you will be provided the contact information for the PAL closest to your area. We are happy to connect with you by phone or virtual platform of your choice. We look forward to hearing from you. Next slide. Again, I'd like to thank Cure SMA for the opportunity, and thank you to the SMA community for listening in today. Have a great day.
Thank you so much, Jennifer. So before we close out today's summit, we're going to go over a few questions that have come in from the community regarding Vanessa's presentation. So in being mindful of time, we'll keep it short. Let's see, the first question. How can we manage tailbone pain while sitting?
So I think that's one of the things that there isn't a specific treatment necessarily for tailbone pain. I think a lot of it's usually positional, and so it's probably partially just from sitting too long in one position, because anything starts to hurt after a while if you're sitting on it too long. So I think one thing is just changing position, either moving around if the person asking is able to move on their own, or repositioning if it's somebody who needs to be repositioned. And then I think it's also making sure that nothing else is going on. If there's a lot of tailbone pain, is there a fracture there? Is there a compression fracture? Is there something else that you want to look for if it's really persisting and not getting better with some of the things like repositioning or sitting on a donut, as we call them, like things that you can get from recommendations from physical therapy or occupational therapy for having some cushioning when sitting. So I think there's some things to try first. If there's really ongoing pain, you then want to figure out that that is not relieved by repositioning or some other recommendations, non-pharmacologic things, then you want to really start to look for what is the source of that and make sure that there isn't something else going on there, like a fracture or something like that. I think something like, ibuprofen or acetaminophen could possibly be used as well, but you want to make sure that you know what's going on, so you're not just masking the cause of something that might be causing that pain.
Wonderful. Thank you for that insight, Vanessa. And then we had one individual ask about a couple of the techniques, and actually they mentioned a few of the resources or tools you had mentioned earlier. So I'll just highlight, they wanted to learn more about if you have anything to share on biofeedback or breathing techniques as well.
Sure. So biofeedback is a very useful technique. It can work very well as part of pain management. Somebody really needs to be trained in it. I didn't include it here. I personally am not trained in doing it, but I know a lot of people that are. and I think it can work really well. You just need to find somebody who can do it. So some of our, for example, our headache psychologist who works in our department, she's trained in biofeedback and uses it all the time. It can be a very effective modality. You just need to make sure that you can find somebody who is able to do that with you. And then the second thing was biofeedback and breathing techniques, I think, was breathing techniques, absolutely. I think that goes along with meditation a lot of times, of just really centering yourself and doing some deep breathing. But absolutely, I also didn't mention hypnosis can be very effective along with deep breathing to manage pain. And hypnosis is often grouped together with sort of guided imagery, even though they are very distinct and different. But hypnosis, I know people who have had amazingly, I know someone who had her knee replaced twice without any anesthetics, just using hypnosis. And this is somebody who is really, really experienced and, you know, teaching other people how to do hypnosis, but went through 2 full surgeries. So it's, you know, it can be, it really is useful. Breathing, hypnosis, guided imagery, any of those things where you can just cause yourself to be calmer, or breathing is different than hypnosis, but hypnosis would be sort of dissociating from the pain entirely. And breathing can be a very useful technique to just really, I mean, if you think about it, if I'm talking really fast and giving all the information and saying things like this, and yes, you should absolutely use breathing versus saying, okay, take a deep breath, try and center yourself, and just calming your voice and your tone and the rate of speech and taking some deep breaths. It can really help somebody calm down. Although my 11-year-old nephew always tells me, don't tell me to take a deep breath. I don't want to take a deep breath. So I think it is a very useful technique, but you have to be in the right mindset. Often when you're in a panic, if you tell somebody to take a deep breath, it might not be helpful. But I think using it regularly, and there's lots of apps and things out there now where you can do this too. There's ones where it's a little circle that I love that kind of says breathe in and then breathe out for the bottom half of the circle. And sometimes I just sit at my desk for a minute or two and just do that to kind of recenter yourself. So great question, great points. Yes, absolutely.
Great. Well, thank you so much, Vanessa. I think that's all the time that we have for questions today. If you had a question that didn't get answered, you can always email us in, and we'd be happy to help answer that question for you. So again, thank you, Vanessa, so much for your incredibly informative presentation today and for your time in answering those questions. So we really appreciate having you on today.
Thank you. Thank you for having me.
Yeah, and also thank you to our other speakers as well for joining in on today's summits, for your time and presentation too. And we appreciate all who joined in on this webinar. You will be receiving a follow-up email with a survey link, and we welcome any feedback that you have to share with us. Also, please visit the QRSMA website to view other upcoming Summit of Strength webinars. And finally, we're just so grateful for all of the support that we've received from our sponsors for making the Summit of Strength webinar series possible. Again, if there's any questions that you have or anything that we can do, please email us at familysupport@qrsma.org. Thank you all so much and have a great day.